Would you like free audiobooks? Click the link in the description. Question 1. A patient is admitted with septic shock. Which initial nursing action is most appropriate? A. Administer broad-spectrum antibiotics. B. Begin fluid resuscitation with isotonic saline. C. Place the patient in a high Fowler's position. D. Administer vasopressors. Answer: B. Begin fluid resuscitation with isotonic saline. Rationale: in septic shock, the priority is to restore perfusion. Initial fluid resuscitation with isotonic saline is critical to expand intravascular volume and improve tissue perfusion. Administering broad-spectrum antibiotics is also essential, but comes after fluid resuscitation. Vasopressors are considered if the patient remains hypotensive after fluid resuscitation. High Fowler's position may help with breathing if the patient is in respiratory distress, but is not the initial action for septic shock. Question 2. A nurse is caring for a patient with hypovolemic shock. Which finding would indicate an improvement in the patient's condition? A. Urine output increases to 30 milliliters per hour. B. Heart rate increases from 100 to 120 beats per minute. C. Systolic blood pressure remains below 90 millimeters of mercury. D. Capillary refill time decreases to 2 seconds. Answer: A. Urine output increases to 30 milliliters per hour. Rationale: an increase in urine output to at least 30 milliliters per hour indicates improved renal perfusion and is a positive sign that fluid resuscitation efforts are effective. A rising heart rate could indicate ongoing hypovolemia or compensatory tachycardia. A systolic blood pressure below 90 millimeters of mercury suggests persistent hypotension, a critical concern in shock. A decreased capillary refill time is a positive sign, but an increase in urine output more directly reflects improved organ perfusion and function. Question 3. When caring for a patient in anaphylactic shock, which medication should the nurse prepare to administer first? A. Methylprednisolone, Solumedrol. B. Diphenhydramine, Benadryl. C. Epinephrine. D. Ranitidine, Zantac. Answer: C. Epinephrine. Rationale: epinephrine is the first-line treatment for anaphylactic shock due to its vasoconstrictive, bronchodilatory, and anti-inflammatory properties. It rapidly reverses the effects of widespread vasodilation, increased vascular permeability, and bronchoconstriction. Methylprednisolone and diphenhydramine are adjunct treatments to manage inflammation and allergic reactions, respectively. Ranitidine may be used as an additional treatment to manage gastric acid secretion but is not a priority in acute management. Question 4. A patient with cardiogenic shock has a pulmonary artery catheter in place. Which hemodynamic reading supports this diagnosis? A. Cardiac output, CO, of 7 liters per minute. B. Pulmonary capillary wedge pressure, PCWP, of 25 millimeters of mercury. C. Central venous pressure, CVP, of 2 millimeters of mercury. D. Systemic vascular resistance, SVR, of 800. Answer: B. Pulmonary capillary wedge pressure, PCWP, of 25 millimeters of mercury. Rationale: in cardiogenic shock, the heart's ability to pump blood is impaired, leading to an increase in pressures upstream of the left ventricle, such as the pulmonary capillary wedge pressure. A PCWP of 25 millimeters of mercury is elevated, indicating fluid backup into the lungs due to left ventricular dysfunction. A CO of 7 liters per minute is typically considered normal or high, CVP of 2 millimeters of mercury is low, and SVR of 800 is at the lower end of normal, none of which specifically indicate cardiogenic shock. Question 5. A nurse is monitoring a patient for signs of neurogenic shock following a spinal cord injury. Which clinical manifestation is most indicative of neurogenic shock? A. Tachycardia. B. Hypertension. C. Warm, dry skin. D. Fever. Answer: C. Warm, dry skin. Rationale. Neurogenic shock occurs due to the loss of sympathetic tone following a spinal cord injury, leading to vasodilation. The hallmark signs include hypotension, bradycardia, not tachycardia, and warm, dry skin due to vasodilation. Hypertension is not associated with neurogenic shock. Fever can occur due to secondary complications, but is not a primary indicator of neurogenic shock. Question 6. For a patient experiencing obstructive shock due to a tension pneumothorax, which immediate action is most appropriate? A. High-flow oxygen therapy. B. Intravenous fluid administration. C. Needle decompression. D. Vasopressor administration. Answer: C. Needle decompression. Rationale. In the case of a tension pneumothorax, air trapped in the pleural space increases intrathoracic pressure, impeding venous return to the heart and leading to shock. Immediate needle decompression is required to relieve the pressure. High-flow oxygen, intravenous fluids, and vasopressors may be supportive measures but do not address the root cause of the obstructive shock in this scenario. Question 7. A nurse assesses a patient with suspected septic shock and notes the presence of petechiae. The nurse understands that this finding is most closely associated with which pathophysiological process? A. Myocardial depression. B. Disseminated intravascular coagulation, DIC. C. Acute respiratory distress syndrome, ARDS. D. Autonomic hyperreflexia. Answer: B. Disseminated intravascular coagulation, DIC. Rationale. Petechiae, small red or purple spots on the body, indicate minor bleeding under the skin and are associated with disseminated intravascular coagulation, DIC, a coagulopathy that can accompany septic shock. DIC occurs due to the excessive activation of clotting factors and fibrinolysis, leading to microthrombi and bleeding. Myocardial depression and ARDS are complications of septic shock but not directly related to the presence of petechiae. Autonomic hyperreflexia is a condition associated with spinal cord injuries, not septic shock. Question 8. When planning care for a patient with shock, the nurse prioritizes maintaining perfusion to vital organs. Which intervention directly supports this goal? A. Elevating the head of the bed to 45 degrees. B. Administering sedatives to reduce anxiety. C. Monitoring urine output and specific gravity. D. Administering oxygen to maintain SpO2 greater than 92%. Answer: D. Administering oxygen to maintain SpO2 greater than 92%. Rationale. Administering oxygen to maintain an SpO2 greater than 92% ensures that sufficient oxygen is available for tissue perfusion and aerobic metabolism, directly supporting the goal of maintaining perfusion to vital organs. Elevating the head of the bed may help with respiratory function but does not directly ensure perfusion. Administering sedatives may reduce oxygen consumption but does not improve perfusion. Monitoring urine output and specific gravity is important for assessing renal perfusion and fluid status but is not a direct intervention to support perfusion. Question 9. A patient with shock is receiving norepinephrine. The nurse understands that the primary action of norepinephrine in this situation is to A. Increase renal perfusion. B. Reduce heart rate. C. Increase stroke volume. D. Increase vascular resistance. Answer: D. Increase vascular resistance. Rationale. Norepinephrine is a vasopressor that primarily acts to increase vascular resistance, systemic vascular resistance, which helps to elevate blood pressure in patients with shock, particularly when hypotension is due to vasodilation, as in septic shock. It does not primarily increase renal perfusion, reduce heart rate, or increase stroke volume directly. Its main effect is on vascular tone. Question 10. In assessing a patient with early signs of shock, which laboratory value would the nurse monitor closely as an early indicator of cellular hypoxia? A. White blood cell count. B. Serum lactate. C. Hemoglobin level. D. Blood urea nitrogen, BUN. Answer, B. Serum lactate. Rationale. Serum lactate levels rise as a result of anaerobic metabolism, which occurs when cells are deprived of oxygen, making it a critical early indicator of tissue hypoxia and shock. While the other values may also be abnormal in shock, they do not specifically indicate early cellular hypoxia like an elevated lactate level does. Question 11. A nurse is caring for a patient with distributive shock. Which characteristic is most indicative of this type of shock? A. Cold, clammy skin. B. Reduced cardiac output. C. Massive vasodilation. D. Increased afterload. Answer, C. Massive vasodilation. Rationale. Distributive shock, which includes septic, anaphylactic, and neurogenic shock, is primarily characterized by massive vasodilation leading to a relative hypovolemia and impaired tissue perfusion. Cold, clammy skin is more associated with hypovolemic or cardiogenic shock. Reduced cardiac output is a feature of cardiogenic shock, and increased afterload is typically seen in hypertensive emergencies, not distributive shock. Question 12. For a patient in cardiogenic shock, which intervention should the nurse prioritize to decrease cardiac workload? A. Administering beta blockers. B. Increasing fluid volume with crystalloids. C. Providing supplemental oxygen. D. Encouraging ambulation to promote circulation. Answer, C. Providing supplemental oxygen. Rationale. In cardiogenic shock, it's essential to reduce cardiac workload and oxygen demand. Providing supplemental oxygen directly helps by ensuring adequate oxygenation, thus reducing the heart's effort to supply oxygen to the body. Beta blockers may be used in specific situations, but are not the first-line intervention for decreasing workload in acute shock due to their potential to further decrease cardiac output. Increasing fluid volume might exacerbate the condition by increasing preload and workload on the failing heart. Encouraging ambulation is contraindicated as it increases oxygen demand and cardiac workload. Question 13. A patient presenting with shock is noted to have a rapid, weak pulse, hypotension, and clear lungs on auscultation. Which type of shock should the nurse suspect? A. Cardiogenic shock. B. Hypovolemic shock. C. Obstructive shock. D. Distributive shock. Answer, B. Hypovolemic shock. Rationale. The presence of a rapid, weak pulse, hypotension, and clear lungs suggests hypovolemic shock, where there is a significant reduction in intravascular volume, leading to decreased cardiac output and perfusion. Cardiogenic shock typically presents with pulmonary congestion evident on auscultation. Obstructive shock involves physical obstructions to blood flow, which may not necessarily present with clear lungs. Distributive shock often involves warm, flushed skin early on due to massive vasodilation, not primarily hypovolemia. Question 14. In treating a patient with obstructive shock caused by cardiac tamponade, which action is most appropriate? A. Rapid infusion of IV fluids. B. Immediate pericardiocentesis. C. High-dose loop diuretics. D. Application of external pacing. Answer, B. Immediate pericardiocentesis. Rationale. Cardiac tamponade, a form of obstructive shock, occurs when fluid accumulates in the pericardium, exerting pressure on the heart and impeding ventricular filling. Immediate pericardiocentesis, the removal of fluid from the pericardial space, is required to relieve pressure on the heart. Rapid infusion of IV fluids may be supportive initially to enhance venous return, but it does not address the root cause. High-dose loop diuretics are not appropriate as they could exacerbate hypotension. External pacing is not indicated unless there is a bradyarrhythmia contributing to the shock state. Question 15. A nurse is caring for a patient who developed shock following a severe allergic reaction. The nurse anticipates administering which first-line medication? A. Dopamine. B. Epinephrine. C. Norepinephrine. D. Amiodarone. Answer, B. Epinephrine. Rationale: in cases of shock following a severe allergic reaction, anaphylactic shock, epinephrine is the first-line medication due to its ability to combat vasodilation, increase blood pressure, and alleviate airway swelling. Dopamine and norepinephrine are vasopressors that may be considered in other types of shock or if epinephrine is not sufficient. Amiodarone is an antiarrhythmic and is not used in the management of anaphylactic shock. Question 16. A patient with septic shock is receiving vasopressor therapy but remains hypotensive. Which additional intervention should the nurse anticipate? A. Increase the rate of vasopressor infusion. B. Administer an additional bolus of isotonic saline. C. Start an inotropic agent. D. Initiate hypothermia protocol. Answer, B. Administer an additional bolus of isotonic saline. Rationale: in septic shock, fluid resuscitation is a critical initial step. If a patient remains hypotensive despite vasopressor therapy, administering an additional bolus of isotonic saline may be necessary to ensure adequate intravascular volume before increasing vasopressor rates or adding inotropic agents, which increase myocardial oxygen demand and could exacerbate the situation if adequate volume is not ensured. Hypothermia protocol is not indicated for septic shock management. Question 17. A nurse notes that a patient in shock has cold extremities, a capillary refill time of greater than 3 seconds, and mottled skin. These findings are indicative of A. Compensated shock. B. Progressive shock. C. Irreversible shock. D. Early septic shock. Answer, B. Progressive shock. Rationale: cold extremities, delayed capillary refill, and mottled skin indicate poor peripheral perfusion, suggesting that the patient is in the progressive stage of shock. During this phase, compensatory mechanisms are overwhelmed, leading to tissue hypoxia, acidosis, and the beginning of organ dysfunction. Compensated shock typically presents with more subtle signs such as tachycardia. Irreversible shock is characterized by profound organ failure and is often not responsive to interventions. Early septic shock might not necessarily present with these peripheral signs, as septic shock can initially cause warm, flushed skin due to vasodilation. Question 18. The nurse is preparing to care for a patient with neurogenic shock. Which clinical finding is most consistent with this diagnosis? A. Hyperthermia. B. Hypertension. C. Bradycardia. D. Hyperreflexia. Answer, C. Bradycardia. Rationale: neurogenic shock results from the disruption of the autonomic pathways within the spinal cord, leading to vasodilation and decreased heart rate, bradycardia. This shock type is unique in that bradycardia occurs instead of the tachycardia seen in other shock forms. Hyperthermia is not characteristic of neurogenic shock. Patients may actually be poikilothermic, taking on the ambient temperature. Hypertension is not associated with neurogenic shock, which features hypotension. Hyperreflexia is associated with spinal cord injury above the level of T6, but not specifically with neurogenic shock, which typically results in a loss of reflexes below the level of injury. Question 19. A patient in shock has a mixed venous oxygen saturation, SVO2, measurement of 60%. The nurse interprets this finding as A. Normal, indicating adequate tissue oxygenation. B. Indicative of increased oxygen extraction by tissues. C. Suggestive of inadequate cardiac output. D. A sign of hyperventilation. Answer, B. Indicative of increased oxygen extraction by tissues. Rationale: a mixed venous oxygen saturation, SVO2, of 60% is below the normal range, 70 to 75%, indicating that tissues are extracting more oxygen than usual from the blood due to inadequate perfusion or increased oxygen demand. This finding can suggest that the patient is in shock, where tissue oxygenation is compromised. It's not necessarily indicative of normal tissue oxygenation, inadequate cardiac output, though this may be a contributing factor, or hyperventilation directly. Question 20. In the context of distributive shock, the nurse understands that the primary mechanism is A. Loss of intravascular volume. B. Cardiac pump failure. C. Obstruction of blood flow. D. Abnormal distribution of blood flow. Answer: D. Abnormal distribution of blood flow. Rationale: distributive shock involves an abnormal distribution of blood flow, where blood volume is misallocated to the peripheral tissues due to vasodilation, leading to insufficient blood supply to the central circulatory system and organs. This type of shock includes septic, anaphylactic, and neurogenic shocks. It is not primarily due to loss of intravascular volume, cardiac pump failure, or obstruction of blood flow, which are characteristic of hypovolemic, cardiogenic, and obstructive shocks, respectively. Question 21. A patient in shock is noted to have oliguria. The nurse understands that this finding is primarily due to A. Acute tubular necrosis. B. Glomerulonephritis. C. Decreased renal perfusion. D. Urinary tract obstruction. Answer: C. Decreased renal perfusion. Rationale: oliguria in the context of shock is most commonly due to decreased renal perfusion as the body shunts blood away from the kidneys to maintain perfusion to vital organs like the heart and brain. This compensatory mechanism can lead to acute kidney injury if prolonged. Acute tubular necrosis may develop as a consequence of sustained hypoperfusion, but it is not the initial cause of oliguria in shock. Glomerulonephritis and urinary tract obstruction are not directly related to the decreased renal perfusion seen in shock. Question 22. The nurse is assessing a patient for signs of compensatory shock. Which finding would be most indicative of this stage? A. Confusion and lethargy. B. Warm, flushed skin. C. Tachycardia and tachypnea. D. Hypotension and anuria. Answer: C. Tachycardia and tachypnea. Rationale: in the compensatory stage of shock, the body attempts to maintain perfusion to vital organs through compensatory mechanisms such as increased heart rate, tachycardia, and increased respiratory rate, tachypnea, to improve oxygen delivery and carbon dioxide removal. Confusion and lethargy are more indicative of the progressive stage, where compensatory mechanisms begin to fail. Warm, flushed skin is characteristic of the early phase of distributive shock. Hypotension and anuria are signs of decompensated shock, where compensatory mechanisms are overwhelmed. Question 23. When managing a patient with septic shock, the nurse understands that the priority intervention is A. Immediate administration of vasopressors. B. Rapid fluid resuscitation. C. High-dose corticosteroid therapy. D. Application of external warming devices. Answer: B. Rapid fluid resuscitation. Rationale: the priority intervention for managing septic shock is rapid fluid resuscitation with isotonic crystalloids to restore perfusion and prevent organ dysfunction. While vasopressors are important for maintaining blood pressure after adequate fluid resuscitation, they are not the first-line intervention. High-dose corticosteroid therapy may be considered in refractory shock, but is not a priority initial intervention. External warming devices may be used to maintain normothermia, but are not a priority compared to fluid resuscitation. Question 24. A nurse observes that after administering a fluid bolus to a patient in shock, the central venous pressure, CVP, increases from 5 mm of mercury to 10 mm of mercury. This change suggests A. Adequate fluid resuscitation. B. Overresuscitation and risk of fluid overload. C. No significant change in the patient's condition. D. The need for immediate diuretic administration. Answer: A. Adequate fluid resuscitation. Rationale: an increase in CVP from 5 mm of mercury to 10 mm of mercury after a fluid bolus in a patient in shock suggests adequate fluid resuscitation, as it indicates an increase in venous return and potential improvement in cardiac preload. CVP readings between 8 to 12 mm of mercury are generally considered optimal for patients in shock, depending on the specific clinical scenario. While overresuscitation is a concern, a CVP of 10 mm of mercury does not necessarily indicate fluid overload but should prompt continued monitoring. Immediate diuretic administration is not indicated based solely on this change. Question 25. In evaluating the effectiveness of shock treatment, which outcome would be the most direct indicator of improved perfusion to vital organs? A. Decreased heart rate. B. Increased mean arterial pressure, MAP. C. Increased urine output. D. Decreased lactate levels. Answer: D. Decreased lactate levels. Rationale: decreased lactate levels are a direct indicator of improved tissue perfusion and oxygenation, as lactate is produced during anaerobic metabolism when tissues are hypoxic. While decreased heart rate, increased MAP, and increased urine output are positive signs of improved hemodynamic status and may indirectly suggest improved organ perfusion, decreased lactate levels directly reflect a reduction in metabolic acidosis and improvement in cellular oxygenation and function. Visit nursestudy.net for more nursing practice exams, care plans, and study guides.